My name is Rakesh Popat and I'm a haematologist based at University College Hospital in London in the UK. At the recent International Myeloma Workshop meeting, I presented an update of the CARDAMON phase 2 clinical trial, which was investigating the role of autologous stem cell transplant versus consolidation for newly diagnosed patients with multiple myeloma, as well as the role of carfilzomib maintenance. What we know from this study really is that it confirms that the standard of care should be with autologous stem cell transplant for patients with newly diagnosed myeloma. And this really confirms data from the IFM and the Forte clinical trial. Now, if we move on to the role of carfilzomib maintenance, this also is adding to the wealth of data that we have with proteasome inhibitors as maintenance following a stem cell transplant. We know that lenalidomide maintenance is standard, but not all patients benefit from lenalidomide maintenance, and specifically those patients with high-risk cytogenetics. What we know from the Forte study is that carfilzomib maintenance seemed to improve the progression-free survival in patients who received carfilzomib and Revlimid maintenance versus those patients who received Revlimid maintenance in those with high-risk cytogenetic features. Now, the CARDAMON trial is still earlier on in the analysis, and what we can see from that is that there was a benefit of carfilzomib maintenance, although this was not a randomized clinical trial. What our study demonstrated was that the high MRD negativity rates demonstrated following the transplant were maintained and deepened with the use of carfilzomib maintenance. Overall, carfilzomib maintenance was generally well tolerated, although the grade 3 adverse event profile was worse following a stem cell transplant compared to consolidation. We are going to wait and see what the impact of high-risk cytogenetic features are in the CARDAMON trial, which I think may add to the data that we have through Forte. So I think there are a couple of questions still pending. The question is carfilzomib maintenance as monotherapy suitable following a transplant, or should it be carfilzomib and Revlimid maintenance? We need to wait and see what the impact of high-risk cytogenetics are. And also, as we've seen in CARDAMON, that there was a higher risk of grade 3 adverse events for patients who are receiving maintenance following a transplant. And so we know we need to be a little bit careful with carfilzomib dosing early on following the transplant. And hopefully we'll see some of this data coming through in the next few conferences. Thank you very much.